Friday Eve.
Joining us now, Dr. Geri Weiland, a pediatrician and immediate past president of the Mississippi State Medical Association. Dr. Weiland, always good to have you in. Good to see you again.
Thank you.
Yeah. So let's start out with the baby formula shortage, something I'm sure that you run into as a pediatrician. That seemed to have just been top of the news there for a while. Haven't heard a lot about it. What's the situation?
Well, the situation is actually getting better. The problem happened spring of 2020 with the closing of a Similac plant in Michigan, Sturgis, Michigan. There's only 4 big players in baby formula in the United States, and Similac, which is Abbott, and Mead Johnson are the biggest players.
Okay.
In addition to having a large share of the market, they also have a huge share of the WIC market, which is women, infant, children throughout the United States. Each state, it's a federally administered program, but each state gets to contract with a formula company. Mississippi has been with Mead Johnson, which is Enfamil, for quite some time. I believe Louisiana is currently with Similac. It really goes from one to the other. It's usually between those two. So when you have the shutdown because of concerns of contamination, then you had a huge chunk. I believe it was about 40% of the formula market was just not available.
Wow.
And that meant that all the other providers were there was a demand for the other providers.
Okay.
And there was just a shortage. I mean, there just was not enough to go around, because the people who were using Similac would move over to Enfamil. And then in the state of Mississippi, about 55% of our children qualify for WIC, and we have Enfamil. So there was a run on that, and it was not available to the state. Now, the other thing that was kind of a perfect storm about this, again, which this happened last spring, so the spring of 2022, Mississippi WIC, which is administered through the Department of Health, moved over starting sometime in the middle part of 2021 to an e-card. So before that, you're the mom and you have a baby, and you would go down to the WIC office, or actually the health department, and you would pick up your month's supply of formula.
Yep.
And you take it home and you would use it. But when they went to the e-card, you then had a credit card that was loaded each month with the amount you could have, and you were permitted to go to certain retailers and get the formula, which of course they were trying to make it more convenient for the moms and a little bit more cost effective for the state, because you no longer had to have the warehouses and that sort of thing.
Sure.
Unfortunately, you're going to give somebody a card to go get something and there's none to be had. It became an issue.
Okay. Is there a problem with the child sort of just moving between different brands of formula? Do they, if they start on one, do they need to stay with that? Because you mentioned that there are only a handful, and that we had shortages of one, and then somebody else filled the vacuum. Is that a problem, moving between them like that?
Well, it's not a huge problem. We like to stay with the same one if we possibly can. Now, it is a problem if the baby cannot take one of what we call the elemental, or the entryway formulas, which are all cow milk based. Okay, so once you move to the soy, which again is not much more expensive, and then you move to the people who have significant allergies, then you start having a problem moving from one to the other.
Okay.
But I thought you were going to ask me what my husband asked. Why can't they just drink milk? So
well, yeah, I was going to ask you, what did we do before we had this formulas?
We try in infant nutrition to mimic human breast milk as best we can. Again, we do, as pediatricians and physicians who take care of babies, promote breast milk because, breast milk is made for human babies and it's the best thing for them. Okay. The manufacturers have tried very hard to simulate that. They start with cow milk, but they add all these other DHA and products like that mimic human breast milk so that we get the best brain development.
I see.
So if we're going to use milk, and of course some of my parents had to do that, then you have to make sure you add vitamins and that kind of thing, and make sure that it's whole milk until age 2. So,
I see. Okay. All right. What about this report we've seen where there are some shortages of ADHD medication?
Oh, that's a whole nother problem. We're going to talk about that?
Yeah. Tell me. What you know about that?
What I know about that is that it has made my life a big pain for the past several months.
Really?
And my nurse is about to quit.
Why is that? Because you can't
get it.
Huh.
You can't, and that is, I do have a little problem moving from one ADHD medicine to the other.
Okay.
And this is where I have a little problem with some of the insurance companies because they think that we can, that they're all M&Ms, just different colors. And it's really, those medicines, I have a little more trouble moving from one to the other. But in the last few months, I've been having to move my patients from one to the other. And sometimes it's because of shortages, and sometimes it's because their insurance will not pay for what I'd like to put them on.
I see. I just haven't heard a lot about that until very recent. We're going to start hearing about it.
It's terrible. One of the Concerta is a big ADHD medication that has a generic methylphenidate ER. The manufacturer is not making it. They're kaput. Stop. They're not making it.
Just not making it.
But most insurance companies will not cover the brand name. So now I have to move all of those children who are on the generic to something else that's not the same. And, I feel for the teachers. I do. I feel for the family and teachers because these medications actually help these children. They help them to concentrate. They help them to learn. And, you can say what you want to about it, but my patients, I don't give you the medicine unless I think it's going to help you. And then I make sure that it's actually helping you and not affecting you in any other way.
How do you test that? So you prescribe it and the patient starts taking it. Do they come back for some sort of test?
We come back and we check them. Well, we ask about, school performance, how are things at home? What's our behavior like? Is it helping your behavior? Is it hurting your behavior? Yeah. Some people use questionnaires, which can sometimes help, but usually I just talk about how things are. How is it going? Are we making better grades? Are we able to do our homework? And, if the child's old enough, they'll tell you, man, this stuff helps.
Yeah. Well, I can say in my youth coaching career that I have coached kids that, say, in middle school, that would be on the medication while they were in school during the school session, and then in the summer, their parents would take them off it. I don't know if that was recommended or they were just fearful for maybe using it too much, but I could tell the difference in the ability to pay attention and to just concentrate and focus from when they were on it during the session to in the summer when they stopped taking it.
It's a different philosophy. I don't insist that, some parents insist their child to go ahead and stay on it because they have behavior problems at home and it helps with that. I know what you're saying. A lot of parents want to give them a break because they do sometimes grow a little better, eat a little better off the medicine. Sometimes it's a financial thing if the parents are having to pay for this medicine. But yeah, you would notice, and they notice too. It's just they're able to put up with it, and hopefully you are able to also. But this does make a point. If a child, if they become a teenager and still do better with the medication, we would hope they take it as they learn to drive and do those things where they need to concentrate.
Yeah, it's interesting. All right, so postpartum Medicaid and postpartum coverage is an issue that our legislature is considering. Very strong opinions on both sides of this argument. I think it's quite fair to say. Those that generally oppose it would say it's just unnecessary. And those that support it can cite all kinds of reasons why we should do it. If you were addressing opponents of the legislature, what would you tell them, Dr. Weiland?
Well, first off, I could go into all the reasons why I think it's very helpful, but I would tell them we've already done it for 2 years. Why do we feel like we stopped? And we did it during the pandemic.
Yeah,
this was fantastic.
That's right.
It was very helpful.
It was required during the pandemic.
It was helpful.
Yeah.
The problem is a lot of people want to see statistics and how we want to prove that it did better. It's hard to collect that data in such a short period of time. But in my practice, I saw it help. I mean, these moms they go get their health problems taken care of instead of telling me about it, and then I have no place to tell them where to go because they have no insurance. Mm-hmm. One of the things we do in my care of children is at 2, 4, and 6 months of age, we have a postpartum depression screen for the moms. We ask the moms, how are you? How are you doing? So, after 2 months, there's still 4 and 6 months that we worry about them having postpartum issues.
We got a break right here, but can you continue this discussion on the other side of the break?
Okay.
Okay. We got Dr. Geri Weiland, pediatrician and immediate past president of the Mississippi State Medical Association in the Element Well Studios. We're back with you in the Element Well Studios. Dr. Geri Weiland, pediatrician and immediate past president of the Mississippi State Medical Association, is our guest in the Element Well Studios. So, Dr. Weiland, just going a little bit into this postpartum coverage issue. So one thing we need to, highlight is that during the pandemic, as a result of some fairly significant changes to the Medicaid program, states were required, as part of receiving their increased match from the federal government, to cover pregnant women who were under Medicaid as part of that coverage group, to extend the postpartum coverage for the mother, not just the child, but for the mother. The child would continue to be eligible. The mother, after 60 days postpartum, is no longer eligible for Medicaid coverage. This extended that out for a year, for 12 months post-delivery. And just wanted to clarify, so in your experience, you've seen situations where it's important for the mother to continue to interact with their physician and postpartum, and those that don't have Medicaid coverage just don't go to the doctor after that 60-day period of coverage.
That's correct.
Yeah.
There are a large portion of complications from pregnancy that happen in the first couple of months.
Okay.
But there is at least, and I don't have the exact percentages, but there is at least a significant percent, at least a third, continue to have issues related to the pregnancy for up to a year.
Okay.
And, if you weren't one of those people, congratulations to you. But if you are somebody who has a problem with your health because you were pregnant and after 60 days you don't have anywhere to go except the emergency room. Now, these people are going to be seen, Gerard. They don't get that.
ER, though.
Don't get that. But, yes, that's
and the
where they're going to go.
hospitals absorb the cost of that because they don't have any coverage, but they're required by law to stabilize them in the ER.
They will be seen. But then they won't get the follow-up, and they won't be seen by their OB specialists. They won't be seen by the people who could actually fix the problem. Yeah. They're going to be seen by somebody that's going to patch them up and send them out and hope they don't come back. As I mentioned before, the most unhealthy thing a healthy woman can do is be pregnant, and most people get fine afterwards, but some people don't.
Yeah. Well, I know you're a pediatrician, so I'm assuming thus you primarily focus on the treatment and the health of the child. And then that
but
role.
You'd be surprised how much adult advice I give out.
Well, sure. I mean, you can't separate the two.
Well, what I find is, and this is one of the reasons why I feel it's important to continue the coverage. I want healthy moms. And if that means giving them some help for 12 months after a pregnancy, then I'd like to do that, because the baby cannot be on its own. We don't want these moms getting so sick that they can't take care of the child and some other family member has to take care of this baby who's not going to be able to take care of themselves in the first year. Yeah. So if we can help these moms, we did it, and I hope at some point we can get some information on how it did help. Other states have that information. Other states, I know Georgia is one that has been doing this for quite some time. Perhaps our legislators could look at that information and see that it has helped them reduce costs, because these people are going to be seen, but they're going to be they're not going to be seen in a proper fashion, and they're not going to be seen by the people they need to see.
It's an interesting point you make about Georgia, because Georgia is a state that has not expanded Medicaid under the traditional expansion program, but has in fact expanded postpartum coverage. That's kind of interesting, because it's one of the 11 states, including Mississippi, that Alabama, Tennessee, Florida, mostly in the South, that have not expanded Medicaid. I know that maybe it's unfair for those of us that focus on numbers and economics and financial matters to say, okay, what is this costing us financially, and how could we benefit financially if we would extend this coverage? But it does seem like, Dr. Weiland, that those that are dealing with these situations with these mothers postpartum, maybe they should come address to make their case to the legislature about the various real live case studies without disclosing any names or confidential medical information, of course. Situations they've seen that where they have averted bad outcomes, or maybe they've seen bad outcomes that could have been averted, and the like. Because I think there's an opinion coming from those that oppose this that say we just don't see the need for this. That most of what happens in that 60 days, and extending that out is really just throwing more money at a situation that maybe even encourages more use of the public systems unnecessarily.
I agree with you. Now, one of the things using the public system, I guess you're referring to maybe having more babies and that sort of
Medicaid,
thing.
Medicaid, and the taxpayers paying for that.
Right.
I think 65% of the babies born in this state are born to those under Medicaid.
I don't think anything's going to deter. I mean, if you feel like you want to be a mom and you want to be a mom again, you're going to be a mom again. Now, you mentioned Georgia. What I think is what I had really liked was when Mississippi State Medical Association had a task force that looked into possible ways to get more coverage for people, not necessarily expanding Medicaid. But one of the things I thought was exciting was what Arkansas does.
Yeah.
I mean, they've been successful in increasing their federal funds and providing it for private insurance.
Coverage, yeah.
I mean, but that's still covering the working poor. And it's, I hear all the time from legislators, well, we want to cover the working poor. Well, right now we're not.
Yeah.
These people, they're out there working. They can't really afford insurance. And they do the same thing. They go to the emergency room. They clog up the system when they could find a medical home and be taken care of better.
Yeah. So what I would say to that it's a point I've made to many members of our legislature and in government is that, and it's something I'm not sure if you're aware of, is recently, as part of the Inflation Reduction Act passed at the federal level back in the fall, it made permanent some of the enhancements to the Affordable Care Act marketplaces, such that a household with income below 150% of the federal poverty level can obtain private coverage in the exchanges for zero-cost premiums. They still are responsible for out-of-pocket costs, but that maxes out at $3,000 a year. That's the most in the exchanges that a person covered by insurance to obtain there would pay out of pocket. Maybe there's some way that we could get the working poor, as you referred to, who would meet those eligibility requirements to obtain private coverage, and maybe some way Medicaid or the Hospital Association, who's offered to get involved in funding Medicaid expansion, could direct their money to covering the out-of-pocket cost.
I agree. I mean, I would like the people who are out there working and can't afford insurance to be able to have a medical home and not have to go through emergency care or ERs and that sort of thing. So I did not know. That's fantastic. We don't seem to be. It's
under the radar, and I'm not sure why, but what I can say, and I know folks that listen to the program on a regular basis, I've probably repeated that exact same scenario 25 times in the last few months to try to educate people about it. And it was actually enacted in 2021, and it was made permanent in 2022. It was temporary in 21, and the data I've asked for is, well, how many of our folks that would otherwise be, our population otherwise be eligible for Medicaid expansion, the working poor, the able-bodied coverage group that's presently not covered in Mississippi, how many of them were directed to the exchanges to buy cost-free private coverage? I acknowledge they still have out-of-pocket deductibles, but I'd also venture to say that there are providers in hospitals that would probably work with them on their out-of-pocket aspect of that, which, by the way, maxes out at $3,000 a year, $3,000 a year. So it's better than zero, which is what we're getting now, and clogging up the emergency rooms where they're really not getting the proper care. And that's just costing all of us money. Those are money pits, emergency rooms are, honestly, because so much of that care is not reimbursed.
Oh, I agree.
Because for the reason you said, it's the folks that don't have any other option, and they get to the point where they got to go do something. And often when they go in, they're beyond a point, or they're past a point where this would have been a lot less expensive, and we would have had a lot better chance at an outcome if they would have gotten early intervention and treatment. I've heard too many of those stories from practicing physicians that have told me. So I apologize for kind of going off on that.
No, I think that I
narrative.
How do we make those kind of things happen? I mean,
I'm working with the legislators to make sure they understand what's available. And Dr. Edney from Department of Health, he's very aware, and he's texted me and said, yeah, we know this, and we're working on educating our team so that they can get the word out as well.
But the moms that qualify for Medicaid are not likely to qualify for that. So I think
they would if they're able-bodied adults, absolutely, with less than 150% of the federal poverty level. Yeah, if their child does, they do. Let's put it that way. Appreciate it, Dr. Weiland. Thanks for coming on.
It's been fun.
Come right back with more on Midday. Stay with us.